We'll be doing a review of Chapter 1 in Module 2410. This module is an introduction to reimbursement. Talks about the different types of systems that we have. On this exam, there are 20 multiple choice questions, and you will need a calculator to answer about 4 of those questions. So our first slide is our learning objectives. So here's a couple of questions and things that you have that kind of show why do I need to learn it besides Ms. Davis's and HIMA and KHIM and our accrediting agencies. You should learn it to assist patients and clients. Also helps to garner accurate revenue for the organization that you're working for. It can help yourself and your family whenever you're getting billed for services. And you can do it. It is a step-by-step process. You make sure that you know the terms, the jargon, and the abbreviation. Make sure you know about the different payer policies and the procedures. Now, let's start with defining the word reimbursement. This is compensation or repayment for healthcare services that have already been delivered. And you'll hear me say this definition again, so it's important that you know what the term reimbursement actually means. Now, we have 3 national models of healthcare delivery, and they vary based on the funding, the number and types of payers that are involved, and then the level of service that is provided. First, we have the social insurance model, which is also known as Bismarck. This is universal healthcare coverage for a set of benefits defined by the national government. The amount of contributions are proportionate to workers' and employers' incomes. So this started in 1883. It is the oldest model, and it was known as the German model. Every worker and employee contribute to a sickness fund, which is a form of Social Security. This is used in France, Japan, and the Netherlands. Next, we have the National Health Insurance Model, which started in 1946 for the United Kingdom. It's known as the Beveridge Model. Government owns the clinics and hospitals. They pay the doctors and health professionals to work in these public facilities. Single-payer system that's financed by the country's general revenue taxes. It is used in Spain and Scandinavian countries. And then last is our private health insurance model. It's the USA model, also used by Switzerland. Many private health insurance companies exist in addition to a federally run program. The private insurance companies determine the premium, but it's not based on income. It's based on the past health risk or the health assessment. They collect premiums to create a pool of money to pay health claims for the workers and the employees who are contributing to the pool. Now, all 3 of these do have forms of hybrid, but usually you can still pick out that predominant model that's going to be found in there. The U.S. healthcare sector has 3 characteristics: the size of the economic sector, the complexity, and then an intricate payment method and rules. The U.S. healthcare sector is large. It is 17.8% of the nation's gross domestic product. It is complex with fragments or subsystems. There's one that's a source of health services, and 2 is the sources that pay for services. We have payers that are CMS, that's our Medicaid, Medicare, workers' comp, private insurance, state funds, and then, of course, a private individual, which would be a self-pay. Subsystems have varied and complicated method payments rules. The payer mix of the type of payers in the group. They have contracts between payers and facilities which vary with each plan. The plan designates the type of reimbursement that the families will receive. The facilities work with many plans. There could be thousands of different plans that they're having to work with. Rates and terms are revised, updated, and renewed on different timetables, so it can make it a little confusing. Now, Henry J. Aaron quoted about the complexity of the payer mix. Administrative monstrosity, a truly bizarre melange of thousands of payers with pay systems that differ for no socially beneficial reason, as well as staggeringly complex public system with mind-boggling administrative prices and other rules expressing distinctions that can only be regarded as weird. So that's Henry J. Aaron, a noted healthcare economist. Now, Medicare is the largest single payer, and let's talk about who they are. They are health insurance for seniors, people with disability, people with end-stage renal disease. Medicaid is a joint federal-state program. It's the largest source of revenue federal for states, and that's for those with low income. CMS is the Centers for Medicaid. It operates in the DHHS, Department of Health and Human Services. In the 2017, there were 137 million people that were either in Medicaid, Medicare, or CHIPS, which is our child health plans. Now, First Mover, or the initial innovator, is a demonstration project to advance healthcare reimbursement methods and models. It changes in federal payment systems are adopted by other payers in commercial environment. So the changes can affect the provider's insurance as well as the healthcare. Usually what happens is the most insurances will follow those federal plans just to kind of stay on track. The federal government pays for active duty, retired military, their family, veterans, Native Americans, those that are injured, and those that are disabled. You can look at the table 1-2 on page 85 to see all of the federal payment systems that are out there. So health insurance. Now let's define health insurance. Insurance is a system of reducing a person's exposure to risk of loss by having another party assume the risk. An insurance company assumes the unknown cost of health care for a person. So health insurance is reducing a person's exposure to risk of loss by having another party assume the risk. There's our reimbursement again. Remember, that's compensation or repayment for health services that have already been rendered. Distribution of risk across pool to account for varying health statuses. The risk is the probability of incurring loss, and then the risk pool is a group of people who will be covered by a health insurance plan. So health insurances receive payments or premiums for assuming exposure to that risk of loss. The dollar amount that the policy holder or certificate holder must periodically pay a healthcare insurance plan in return for their healthcare coverage is the premium. The insurance company then assumes insured's exposure to risk of loss in return for that premium. Actual data used to calculate the amount of premium needed to cover all groups' potential health costs, and the insurance company pools premiums to ensure that the pool is large enough to pay losses for the entire group. So again, the premium payments for the group combined in that pool of money must be large enough to pay losses for the entire group. Premium payments for insurance are calculated to pay for all potential covered healthcare costs for an entire group of patients. So health insurance is to offset expenses of injury and illness. In 1847, the first sickness clause was in effect, and it was there till about the 1920s. And it looked at the major cost at that time was not necessarily illness, but it was a loss of wages. So in the early 1900s, individuals purchased sickness funds instead of health insurance. Sickness funds are like today's disability, and it helped to deal with that lost wage. Many European countries had adopted forms of nationalized health insurance by the 1920s. However, in the U.S., efforts for the compulsory nationalized health insurance were opposed by physicians, pharmaceutical firms, and insurance companies. The U.S. development and evolution, the first health insurance in the United States was in 1929. It was offered by Blue Cross Blue Shield to school teachers in Texas. In the 1940s and World War II, there was executive and judicial acts to address labor shortage. It became the basic structure of the U.S. insurance, and these acts are why insurance is linked to employment in the United States. Now, in the U.S., health insurance is usually provided through employers, so insurance is closely linked to employment. For a larger employer, health insurance is part of that package. When people experience a job loss, they often experience a loss in their health insurance. So we do have the COBRA, which can extend, and then the ACA, which is the Affordable Care Act. We'll talk more about those in just a minute. You can enroll in those through the federal marketplace. So we have different types of coverage. Single coverage, that's individual, it's healthcare coverage for the employee. Dependent or family coverage, that's coverage for the spouse, partner, employees, and you do usually have to pay extra for those. The employer may pay a portion of the employee's premium for health care insurance. The employee must pay the remaining portion plus premium for all dependents. So when people lose their job, they also lose their health insurance. So they can continue, but with COBRA, the payments are extremely expensive. They also have affordable care, which allows people to go in and sign up in the marketplace for insurance. Now, Medicare is also insurance. Payroll pays the payroll taxes actually help to fund and the portion of Medicare. Premiums by eligible individuals are matched with federal government funds to complete the entire package. So when you're talking about Medicaid, Medicare, it's coming from federal government. It's also coming from premiums for the individual and then payroll taxes. For some employed people, adequacy of insurance is a issue, and it requires people to pay 20% or more for insurance costs. So now, again, remember that the federal government helps to fund portions of health care for seniors, persons with disability, end-stage renal disease, low income on Medicaid, Native Americans, active duty, retired military, veterans, and their families. All of those are covered by the federal government. So again, remember that reimbursement is compensation or repayment for health care services already provided. We have three parties in our payment. These are the third-party payment or payers. A party is the entity that receives, renders, or pays for health services. So first party is the person that receives services or the responsible person receiving the services. This could be the patient, the child, a resident, the parent for a child, adults on their own, and they're known as the guarantor. Second is the entity that is providing those services. They're the provider. Could be a physician, hospital, home health, nursing home clinic, DME provider. And then the third party is an uninvolved party that pays for health services. Could be health insurance, workers' comp, Medicare. If it's self-paid, then they would pay their entire bill. Important to know the different parties and be able to pick out who is who. So to receive a reimbursement, you must submit a claim. A claim is a request for payment for services that's provided to the patient. That claim is going to include your diagnosis, which treatment was received for. The charge is a set dollar amount. That's the price for the item. It's also known as the fee. The provider submits the claim to the insurance company or third party. Then we have adjudication, which is a process in which the payer verifies that all billing requirements have been met and determines which services are eligible for reimbursement. Third party does this once the claim is received. Once completed, the insurance company provides reimbursement for the services that have been rendered under those covered cost. So we have two different types of healthcare methodologies. We have retrospective and prospective. Retrospective is based on the actual resources that are expended. Total amount of resources are usually not known until after they're delivered. The risk is on the payer because the payer's costs are unknown until after the service is rendered. Some examples would be a fee schedule, percentage of the billed charge, or per diem. And Table 1-4 compares those three examples. Now, it's predominantly, if we go back and look at history, it's predominantly been retrospective. The payer determines that reimbursement after the patient receives that service. Now, prospective, providers receive a predetermined amount for all services provided during an episode of care. The provider faces fiscal loss if the costs exceed reimbursement, so the provider achieves profit if the costs are less. The risk is on the provider side because payment rates are established in advance and fixed for a specified time frame. So with prospective, we have capitation, case rate methodology, global payments, and bundled payments. But basically, the payment is determined before the services are rendered. They look at an episode of care, and the care is delivered over a defined period or unit of payment is the encounter period. And that's the provider will be paid based on that episode of care. Now we're going to talk about retrospective first. Retrospective has a great uncertainty. There's no way to know the number of days or services that will be provided. There's few incentives to control cost. Providers are paid based on services, so the more services, the more reimbursement. Critics say that retrospective inflates the cost. Let's talk about the fee schedule. This is a predetermined list of fees that the payer allows for payment after a set of healthcare services. So this is the allowable charge. It's the average or maximum amount the payer will reimburse providers for. The contracting unit is an individual service, and the total volume of services are unknown until the visit or encounter is complete. Our percentage of bill, this is when the payer has negotiated to pay a reduced fee for services provided to their insured members. This is rare. It is seen some in cancer centers and children's hospitals. The contracting unit is the claim. So an example here, if the payer says they'll pay 70% of the billed charges for chemo and the charge is $1,000, then the reimbursement would be $700. Now, a retrospective per diem, also known as the per day or daily rate, the payer reimburses the provider a fixed rate for each day a covered member is hospitalized. It's prevalent in the inpatient setting. Medicare also uses it in inpatient psych hospitals. It's a fixed rate, but it may vary by the type of service. So what's in ICU may be different from the general surgery. All services rendered within a day are reimbursed with a daily rate. The contracting unit is an inpatient day. Retrospective because the total number of days at each level of service is unknown until after the care is provided. Critics say that providers increase the length of stay to increase reimbursement. Per diem rates are set using historical data. If there's no historical data, they look at cost, lengths of stay, volumes of service, and the patient's severity of illness. Now moving to our perspective, the capitation, this is per capita or per person. The payer reimburses the provider a fixed per capita amount for a defined period. You do sometimes see per member per month, which is PMPM. That's the amount of money paid each month for individuals enrolled in the insurance plan. The contracting unit is the person or covered life. The volume or intensity has no impact on that reimbursement. So more services do not increase pay, less services do not decrease the pay. Providers can attempt to control utilization by engaging in population health. They can do this by screenings, wellness plans, and these decrease the complexity of the unknown, so there is no uncertainty. These people are always guaranteed a customer base from that third party, and they always know the cost. The provider can contract to pay services for a group, and the provider receives payment regardless of if all receive the services. Our case rate under perspective, this is also known as case-based. The payer reimburses the provider one amount for the entire admission or encounter regardless of the number of service or length of admission. This is only used in inpatient acute care activities. The contracting unit is the episode. Providers can profit or experience loss based on the cost effectiveness. So higher payment if the stay is longer. They receive payment even if the stay is shorter. Providers can earn profit or experience loss based on the cost of providing care. It encourages cost control. It does reward effective and efficient care delivery. Payment is determined by historical resource on the needs of a typical patient with that condition. The payment allows the provider to make money if the costs get below regular cost. Providers lose money if they exceed that average cost, which could be scheduling delays or duplicate labs that are being done. So global payment in our perspective system, one combined payment to cover the services of multiple providers who are treating a single episode of care consolidates payments into one. This is typically used for physician services and outpatient care. The contracting unit, again, is the episode, and several examples of this. Outpatient dialysis, which would include services, drugs, labs, equipment. The global surgical package, which is OR anesthesia, pre and post appointments. It could be a special procedure pack, OB services, ambulatory visits. There's no additional payment for higher volumes of service or more expensive complex services. And then our prospective bundled predetermined payment amount is provided for all services required for a single predefined episode of care. There's a lump sum payment amount that's designed to pay for multiple providers coordinating care. Our contracting unit is the episode. Typically, a service or onset of a condition initiates the episode of care. All treatment provided for the condition during the specified time frame is paid. Typically, a service or onset of a condition initiates that episode of care, and that's called a trigger. Once triggered, payment for the trigger event plus a predetermined set of services for a set time frame are paid. Care must be carefully considered so all providers receive payment. Need well-defined time frame. Now, there was an example that they talked about in the text, which is the MD Anderson Head and Neck Cancer Bundle. This was a pilot to determine if bundles were successful. The results were positive, but it did show that there was a high administrative need and that burden of the administration part could cause hospitals to not want to use that system. So again, kind of summing up the criticisms of retro and prospective. For retro, few incentives to control cost, little incentives to order less expensive services, rewards providers for more services regardless of whether services are warranted. The prospective criticisms creates incentives to substitute less expensive procedures and tests. It creates incentives to delay or deny procedures and treatments, and there's no quality component. Now, our trends in healthcare that kind of affect all, first of all, constantly increase in healthcare spending. Secondly, efforts to reform the healthcare system. These are trends that affect reimbursement. So in 2015, $3.2 trillion was spent on healthcare. Each year, national spending on healthcare increases. As the money is spent on healthcare, more and more, there's less for other areas, education, safety, that type of thing. 17.8% of the gross domestic product in 2015. With healthcare reform, the exact parameters and framework are on an ongoing debate. We have increased spending on healthcare. That's one of the problems, that excessive costs. Unsafe, inequitable, and poor quality of care. 2000 report to errors human showed the number that die per year because of medical errors, which is more than people dying from car accidents. And then also crossing the quality chasm was the report that showed poor quality of care in large numbers of patients. We also have health disparities and lack of access to care. This can be population specific. We have underserved areas. There's the decreased number of providers, high infant mortality, extreme poverty. They may have a higher percentage of the elderly. And we see these inefficiencies in healthcare, which are unethical and can increase the cost. All health disparities lead to uninsured or underinsured people, and it could be that they lack transportation to get to the doctor, and there can also be language barriers. Now, the Affordable Care Act started off Patient Protection Affordable Care Act of 2010, and then we had an amendment, the Healthcare and Education Reconciliation Act of 2010. Both of these together are known as the Accountable Care Act, Affordable Care Act, or Obamacare, all fall under the same name. It had two purposes. Well, let me say this. It addressed those health system problems of excess cost, poor quality, lack of access. It has two purposes. One is to decelerate the rate of increase in healthcare costs. The other is to improve population health, healthcare access, and healthcare quality. That ACA has 10 titles with subdivided into subtitles with parts and sections. The requirement is then phased in between 2010 and 2020. So we have 10 titles. The key points are listed on page 14 through 16. Title 1 is the quality, affordable health care for all. Title 2 is the role of public programs. Title 3, improving quality and efficiency of health care. 4, prevention of chronic disease and improving public health. 5, healthcare workplace. 6, transparency and program integrity. Next, we have improving access to innovative medical therapies. Number 8, class community living assistance services and support. 9 is the revenue, and 10 is the strengthening quality, affordable care for all. And again, you can read about the key points in each one of those on pages 14 through 16. So now there are 20 multiple choice. You do need a calculator. 4 questions are looking at payer reimbursement, and you may need a calculator to compare the cost when it's asking you to look at the different premiums that need to be paid. That's chapter 1. Good luck on your tests.